The problem with data. Data is held by scientists as the truth, the Bible if you will, but it really isn't quite so simple. There is no such thing as pure data. The saying numbers don't lie is a myth. Today we'll talk about data using the example of Maria van Kerkhove saying asymptomatic spread is rare. Last week, the WHO technical lead came under fire for saying asymptomatic spread of the coronavirus is rare. This is her apology. I'm going to read a whole thing because I think it's very important to understand the difference between modeling and data. Modeling studies estimate that up to 40% of coronavirus infections could be transmitted by people who have the virus but no symptoms. A World Health Organization expert acknowledged after a comment on Monday that asymptomatic transmission was very rare, caused a stir. But Dr. Maria van Kerkhove maintained that the real-world data suggested it could still be a rare event when she took part in a social media Q&A to explain herself, saying she was not referencing the modeling studies when she spoke. Van Kerkhove, the WHO's COVID-19 technical lead, said that on asymptomatic transmission we don't have the answer yet. Her comment at the WHO's Monday press briefing about its rarity was based on 2 or 3 studies following up the contacts of asymptomatic people and unpublished data shared by countries or experts with her organization. I use the term very rare, and I think that it's a misunderstanding to state that asymptomatic transmission globally is very rare. What I was referring to was a subset of studies. I was also referring to some data that isn't published, she said. Let me break it down for you. She basically said that she was relying on real-world data for her statement that asymptomatic transmission is rare, whereas other people relied on modeling studies, which she implied is inferior because she says she can still be right, which means the modelers are wrong. You may have heard of modeling in the news the past few months. They talked about these extremely high death rates if we did nothing to stop the coronavirus. Who knows if they're right, as we didn't do nothing and the death rates weren't as high as they predicted. Maybe they were right. While some people may think modeling is simply guessing because they have no data, it's actually not correct. This is the first of a 35-page report on modeling the impact of non-pharmaceutical, meaning not drug, interventions in Europe from the Imperial College of London, probably the most famous institution for modeling. If you have time, I recommend reading it as they do a great job of explaining what exactly they're doing, but I'll summarize it for you. How do you know how many people are infected when testing was so limited back in March? You can't. So they made up an estimate using observed deaths to calculate the total number of infections there were. They didn't just make up a number. To see the effect of interventions like quarantine policies, they looked at the change in death rates over time, presuming that if there is an effect of the quarantine policy, the death rate should go down. There is also data, numbers here. Then, using a conditional model, assuming that interventions change the infectious number or not, they project or simulate the past to see if their model fits the death rates they do have, and if it does, then they try to use it to go forward and predict what would happen in the future. So why does Maria van Kerkhove not call it data? Well, in a model or simulation, use the raw numbers to come up with predictions for the future. Look here, it's not yet June 22nd, but they're already telling us what will happen next week. Wow! Is this magic? Of course they don't know. They aren't saying this is science, this is set in stone. They're saying with their mathematical models, based on what they know, they think this should happen. A sophisticated way of guessing for the future, based on what we know right now. But if you scroll down a page, you get to estimates of the current effective reproduction number. This is data just in a way Maria would like it. This is basically what a study would do. Take the numbers, crunch the numbers, make some conclusion. And they did it. They know how to do it. But they went one step beyond and used it to try to make predictions about the future. You remember the WHO mass report which defined what asymptomatic versus pre-symptomatic versus symptomatic transmission was? It talks about studies here. It says in one study in China, they looked at 63 asymptomatically infected individuals, meaning that they have no symptoms but have tested positive for the virus, likely by PCR, and they had evidence that 9 or 14% of them infected another person. And they mentioned other studies which show no asymptomatic transmission. What does this mean? Is the data inconsistent? Can studies be wrong? There's a quote from Charles Sidney Burrell, a prior dean at Harvard, which every one of us who have gone through medical training know. He said, half of what we are going to teach you is wrong, and half of it is right. Our problem is that we don't know which half is which. Yes, studies can be wrong. Yes, scientists can be wrong. For so long they thought the sun revolved around the earth. You might have heard of Ptolemy or Aristotle, brilliant minds of their day. Well, they believed the sun revolved around the earth. Let me show you what a study looks like. This is a randomized, double-blinded, active control clinical trial, the highest quality of study. It's called an all-hat trial, and it compared a category of medication called an ACE inhibitor. You may have heard lisinopril or Zestril versus a calcium channel blocker, amlodipine or Norvasc, versus a diuretic, hydrochlorothiazide or Aquazide. These are all blood pressure medications, and they're comparing them. If you look at the results, there will always be a number called a p-value. This is a value that is the most important thing to look at. It's a measure of how likely it is that this result would have happened just due to random chance. By consensus, the cutoff is set at 0.05. If the value is less than 0.05, that means it's statistically significant. And in general, people say it's meaningful. If it's greater, then we say, well, maybe it's just due to luck, chance. As you can see, chlorthalidone, the drug on the far left, seemed to perform well, and it actually revived an interest in using diuretics for high blood pressure when it had been falling out of favor. But there's two important things to know about a study. First of all, is the data valid? There has been recently a lot of news about studies published in the New England Journal of Medicine and Lancet. People question whether or not the data was accurate. First of all, it seemed like they had collected an awful lot of data in a short period of time. And when people actually investigated this company called Surgisphere and asked hospital systems whether to contribute their data to Surgisphere, nobody actually said yes. The universities listed as collaborators on Surgisphere's website, like Stanford, said they have no record of anyone there working with Surgisphere. Awfully fishy? But data could also be made up in a less malicious way. For example, here are the baseline characteristics of a study population. In a study, you need baseline data to make sure the different arms or groups of a study, as in one group trying chlorthalidone versus the other group trying amlodipine, are similar. For example, if the two groups are very dissimilar, one group being 20 years younger than the other group, and the younger group performs better, it's most likely not the medication, it's just the fact they're so much younger. If you look closely, you could see they measure something called HDL-C. This is what is commonly known as good cholesterol. Low HDL means you have an increased risk of heart disease. They're studying heart disease, so it makes sense to include this number. They use the value of 35 as a cutoff, but what if a lot of people had the value of 0? 0 would be less than 35. What? You don't think that's possible? My friend was reviewing the data set for a study and noticed the albumin level was 0 for many of the patients. "What is this?" she yelled. Obviously, it was just that they didn't get the value of albumin for the patient, so someone brilliantly had decided to put in 0, probably because the computer didn't like a non-numeric answer. But a 0 albumin basically means you're dead. So that's wrong. It's immediately obvious to anyone who's looking at a data set who has experience. But if nobody caught it, then those people would have been lumped in the category of people with albumin levels less than 2? And in the AHA study, the people who didn't have values for HDL will be classified as high risk for heart disease? We actually don't know that's correct. And that's why reputable journals like New England Journal of Medicine have a peer review process. You want somebody else to look it over to make sure something isn't missing. They're not misrepresenting the data. And people think they messed up in this case. When things get published, there's obviously another level of scrutiny. The public gets involved. Twitter, everything. And that's when people started wondering about the Surgisphere data. How could it be possible they have so much information when it seems like nobody else has this? And the last issue with data, whether or not it applies to you. In China, people are almost all Han Chinese, 91%. In the US, there's many of European backgrounds and African Americans as well, a unique population. In Iran, there'd be lots of Persians. Ethnicity matters because the genes you have are different, and how one responds to medications is influenced by your genes, and your susceptibility to infections like the coronavirus could be as well. For example, in the AHA study, they used a medication called an ACE inhibitor. A well-known side effect is a dry cough. It's reported to be 5 to 20% in literature, meaning in studies, meaning from data, reportedly. But doctors who worked in clinics saw that many of their Asian patients complained of a cough. Is the data wrong? This study saw the incidence of a cough at 48%, meaning 1 in 2 patients. That's a lot higher than 20%, which is 1 in 5. And other studies have confirmed that Asians are much more likely to have the side effect of cough as compared to Caucasians. And many doctors who have Asian patients don't even bother prescribing this class of drugs to them anymore. But was the data wrong? Let's go back one last time to the ALHA study and look at the participants. Basically they're either black or white or Hispanic. 5% other, meaning Chinese, Korean, Japanese, Thai, Indian, Turkish, Persian, etc. would all add up to 5%. The data collected in the study wasn't from Asians, and thus the results, drawn from mainly white and black and Hispanic, aren't as applicable to Asians as we have seen with the issue of a cough related to the ACE inhibitor. In summary, data can be wrong in multiple ways. It isn't the gospel truth. The numbers can be made up, like in the Surgisphere case. The numbers can be collected inappropriately. Maybe somebody filled in 0 for the result when there was actually no information available. And if the population is different, like how in China, percentage of white people is basically 0, and Estonia it's 99.98%, maybe asymptomatic spread could be more common in one country than another because the people are different. So I'll leave you with a modernized version of Dean Burrell's quote. Half of data is wrong, and half of it is right. Our problem is that we don't know which half is which.